This is Michael Smith of MedPage Today. I'm in Miami Beach at the annual meeting of the American College of Allergy, Asthma and Immunology. And I'm speaking with two of the prominent members of the college. Dr. John Oppenheimer of the New Jersey Medical School is the program chairman for this conference. And to his left is Dr. Gailen Marshall of the University of Mississippi Medical Center in Jackson, who is the chairman of the journal in which all of the abstracts for this are presented, the Annals of Allergy, Asthma and Immunology. Gentlemen, welcome.
Thank you.
Thank you, Michael.
I'm going to ask you very briefly, each to pick your favorite baby from this conference, your favorite study. What do you think was the most interesting, the coolest, the most profound study that you saw of the many that are being presented here? Dr. Oppenheimer?
Well, I think one of the cool studies was the use of nasal saline irrigation. We're seeing a lot more people using homeopathy, and we believe because it's innocuous, it has no ill effects. And in the study, what they looked at was the chronic use of nasal irrigation. And what they saw was that there was actually an increase in nasal effect, not a decrease in nasal effect, when used prophylactically. What I find interesting about it is it makes empiric sense that you'd want to clean out secretions, but the question we have to ask is, are these secretions somehow protective, or do they help diminish infection?
Yet at the same time, I think what it speaks to is that Mother Nature was very smart in giving us these secretions for a reason. When they occur in excess, or when they get infected, or other abnormal situations associated with disease, it makes sense that cleaning those out would actually be good. But then if one continues on a regular basis, perhaps when it's not really needed, it may be washing away what nature intended for us to have as a protectant. And this abstract that John's referring to speaks to that possibility.
I see. Is it fair to say that the abstract suggests that perhaps snot is good? I hate to be vulgar, but...
On a chronic basis, I think what was alluded to by Gailen is, what about acutely if somebody has an infection? There, the snot, for lack of a better descriptive, may have a consistency that may actually dampen your ability to fight infection, or may impede the flow in your sinuses. And I think that the next study that needs to come is to look at it acutely and see if it really does help somebody fighting a common cold.
I see.
And what I would tell you is that I think most of us were trained, John and I were both trained, to believe that you do move this away, and that most patients would suggest that the use of saline acutely during an acute infection or even an acute bout of allergic rhinitis is something that they find that's useful. What happens is it's like anything else. A person can become habituated to doing it. They get in the habit of doing it, and so they don't think about it. And the question that this abstract raised is whether that's something that we ought to interrupt and tell people they really should use this more on an as-needed basis than on a regular basis.
Interesting study. Dr. Marshall, what's your favorite?
I think my favorite study was a review that looked at the current recommendations for vaccines in adults. And the reason that's so important is that I think just about every physician, from the time they're a third-year medical student and do pediatrics, whether they go into peds or whether they don't go into peds, they have an appreciation for the fact that there is a standard for normal pediatric immunization from the day the child is born up through adulthood. And it's easy enough to look up, it's revised and so on. These standards for adults are a little bit less well defined, in particular whether it's done for healthy reasons or patients at risk for certain diseases. What particularly interested me, and it's applicable to me as an allergist immunologist because I take care of a large number of asthma patients, is the specific recommendation now for well-controlled, good adult asthma patients up to age 64 should have the pneumococcal vaccine given once during that time. That's new information. And that came from the CDC very recently, in fact within the last year, as a recommendation, and is now just being disseminated out to those of us that take care and provide first-line therapy for asthma. That's new information. The data are suggesting that with that vaccine, that will reduce the risk of a pneumococcal pneumonia, which is clearly, I think we all know, has a more sinister clinical course in asthma patients than they do in non-asthma patients.
I see. Now that's a study. Those are the two studies. Are there other themes that you think are have emerged here that are of importance to the general population, general clinical population?
But building upon that, I think that we as allergists really are sentinel in delivering many of these vaccines, because people that are either egg or gelatin allergic would not be able to receive the vaccines without the help of an allergist. So recently in Gailen's journal, The Annals of Allergy, we saw a whole supplement dedicated to vaccines and how the allergist can intervene in patients that may be allergic.
Okay, and I think we're reporting on that this week. Is there, are there other themes that have emerged here? So these meetings are variable from year to year?
Another area that's important, it's sort of recurrent, but it's raised another, I think, important emphasis for the public and other healthcare providers to understand is anaphylaxis. That systemic mast cell-mediated reaction that's potentially fatal if not treated carefully and immediately. And I think the big message that's emerging from this and is the final buy-in and consensus among providers, anyone, that first-line therapy should always be administered, or intramuscularly administered epinephrine. And that epinephrine, or adrenaline, as people would call it, is something that has at times been used by providers as a second line or even in some cases a third line. There was a study that was presented here that looked at where across the country emergency medical technicians, whether they used it quickly, if they were authorized to use it, if they were not authorized to use it at all. And the spectrum went from they could make their own clinical judgment to use it to they could assist others in the use of it if they had their own injectable epinephrine to they couldn't do it no matter what. And that's in 2 states out of the country. So it varies. But with the clear information that early administration is directly proportional to survival from this, we now have got that information and are getting our providers to begin to understand it. We have to get the public out there as well. And the reason for that is that most providers and someone who's had anaphylaxis, and I think virtually all allergists, immunologists, we would write a prescription for an injectable epinephrine product. And those have gotten better and better in terms of their technology and their packaging and so on, but they still don't work if you don't carry them. It's like an insurance policy. If you need it, you don't wait and buy insurance until you need it. You have to have it beforehand. So someone who buys their injectable epinephrine and keeps it in the glove box, there's a temperature problem. In the summertime, I'm from the South, and in the summertime, you would not keep it in the box. You would not keep it in the north, in the car, in the dead of winter, because it would freeze. The 2 temperature extremes are not there. But more importantly is that they can't go out for a hike and leave it in the car, even in ambient temperature. They get stung out there, or heaven forbid, they get into something that could create an anaphylactic reaction. They need that, and they need that in 1 to 5 minutes after they first experience symptoms.
Reinforcing that. Well, reinforcing was one of the abstracts presented at this meeting. Highlights that people had either not been carrying their epinephrine kits, or they had kits that really were no longer, shall we say, updated. And I think that's just as dangerous. What was pointed out, and I think is really important also, is we're beginning to see a consensus amongst groups. We recently published an article in the Annals highlighting that emergency room docs and allergists are coming together and agreeing with regard to prioritization of epinephrine early.
Right. And the argument is now you have a illness that has a death rate associated with it. And that death rate is virtually, there's nothing that's 100% preventable, but certainly with the early use of epinephrine, it's 90% preventable. So you have an individual who's got a problem that can be fixed and certainly adequately treated. The delay in the use of that for a time was related to the provider that was taking care of them. That is becoming less prevalent. Now the major thing is to make sure we get that message to the public, particularly those who've experienced it. We're not talking about somebody who's about to have their first episode. We're talking about somebody that's had 2 or 3 or 4 episodes, and they come to the office for their checkup, and we ask them, where's your injectable epinephrine? Oh, it's out in the car, or oh, I've got it at home, or it's in my locker at the office. And we try in a non-pejorative way, we don't want to be parents, but we want to be counselors, is to help them understand how dangerous that practice is, because when they need it and it's not available, they'll think of where it is, and it may be the last thought that they have.
That's a good place to end, I think. That's a clear and potent message. Thank you both.
Thank you.
In Miami Beach, I'm Michael Smith, MedPage Today.